Welcome everyone tonight. I want to introduce our special guest tonight is Dr. Bobby Mukkamala. Here we are at the medical brief with Dr. Brian Smutzler, Dr. Jeremy Hefner, and myself, Dr. Ankit Patel, board certified anesthesia, and trauma general surgeon. Dr. Mukkamala, we want to introduce you to the general public and all of our physician community. Thank you for joining us tonight.
Glad to be here. Thank you.
A lot of questions we want to ask you, and hopefully you have a lot of questions for us to kind of engage with the physician force.
Looking forward to it.
I want to start by asking you, tell us about yourself and how you came to become our president-elect for the AMA.
Yeah, so I'm an otolaryngologist, ear, nose, and throat doc, and I guess my path to medicine. My folks immigrated here to Flint, Michigan, where we are today, from India in 1970, and grew up here in town. Went down to Ann Arbor for 7 years for undergrad and med school, where they had one of those programs where you get right into med school from high school. You know, that 7-year program. You know, every Indian parent especially, would dream.
I know well.
And so did that. Went to Chicago for my residency. Spent 5 years there doing otolaryngology at Loyola.
That's right.
And then Nita would say that I impregnated her with twins and dragged her back to Flint, Michigan, where there's parents and in-laws to help take care of them. So been back here in Flint for 24 years. Nita and I set up an office, so she and I share an office together. Otolaryngology and OBGYN, not necessarily a logical combination of specialties, but marriage makes it work.
That's right.
It's kind of earwax on one side and pap smears on the other side of the office. But you know, when I started my practice, obviously you don't learn everything you need to know about taking care of patients in medical school, as much as we think that's the case. And so when I finished med school, finished residency, came here to practice, started seeing patients right away, you know, 5 patients on the first day, ramped up within the first 6 months. But the billing and collections for the work that I was doing was lagging behind. Like literally seeing 10 patients in a week, doing everything right. You know, the notes were impeccable, right? Like 3-page notes for a deviated septum. Nothing, I don't even do that anymore, but like fantastic. And getting denied for the procedure after I performed it and not getting paid for the septoplasty. I'm like, what the heck's going on here? Like, this just ain't right. And realizing like the stupid reasons. This is before electronic billing on HCFA forms. And, you know, if this isn't in the right exact space on this HCFA form, they're going to deny the payment. And I was mad. So my solution at the time was, you know, I'm going to go to law school. I'm going to get my law degree and I'm going to sue these insurance companies in small claims court, like a Judge Wapner, Judge Judy sort of approach for every claim that they denied. And so I went down to Michigan State University, and they had this night school evening sort of law school degree you could get. And I went down to the orientation. I was all excited to do it. And I met somebody around that time that said, you know, you don't have to do that. You can join the Michigan State Medical Society, and they will take care of these things for you. They are your advocates. You tell them what's going on. You can, you know, decide what resolutions you want to pass, identify the problems, get involved in organized medicine. And that sounded much more reasonable. Yeah. I mean, the kids were 4 years old at the time. If I was disappearing every evening to go try to get a law degree down in Lansing, there was going to be a divorce happening real fast. And so I ended up not pursuing the law degree. Instead, went to a meeting of the Michigan State Medical Society, my first one. And it was in March here in Michigan, and every now and then we get a late snowstorm. And so it was kind of an ice storm in March. 4 people showed up for the young physician section of the Michigan State Medical Society meeting. And it just so happened that there were like 4 positions to elect, you know, president-elect, treasurer, and member at large. And so my first meeting, I became member at large of the YPS of the Michigan State Medical Society. And 4 years later, I'm the chair, I'm on the board. And so that's how I kind of got involved in organized medicine. But, you know, a fantastic way to get problems addressed.
Sure.
You know, to have an idea, have a problem, not have to think of that solution on our own. And instead have an organization in organized medicine to help deal with those problems. And so got involved with the state society, county society, because not all problems are state level. A lot of them are local and unique to the local area. So I've joined the local medical society board and then eventually represented Michigan at the American Medical Association as an alternate delegate and then as a delegate. and then got elected to serve the AMA on the Council of Science and Public Health, which is kind of an 8-year gig. And then at the end of that, usually when you serve on council, you have a decision to make is, do I want to continue serving the organization in some capacity? And I decided to do that. So in 2017, I got elected to the Board of Trustees of the American Medical Association. And then just this past year got elected as its president-elect. Kind of the tail end of board service at the AMA is, again, you make a decision about, do you feel like continuing to serve the organization and healthcare in this capacity? And if so, then you try to become president-elect. And that's what I am now.
Which is amazing. And congratulations on that. But
Thank you.
That's a 20-year commitment.
Yeah.
That was a very long time to be committed to the cause. And you were committed to the cause enough to almost go to law school, but you found a better route to take care of that, which is amazing. So
It seems odd to call it a commitment because it's a mechanism for me to solve my own problems, right? And in addition to that, solving the problems of physicians in general. But I never looked at it as, oh, this is something I got to do or I'm obligated to do. It was always more like, this is helping me, right? Like these are issues that I have in my own practice and that physicians across the country have. And here is an opportunity to help solve those problems. And so it didn't really ever seem like a commitment. It just seemed like a resource that I had. Right. And a voice. Yeah.
So what drew you to otolaryngology? And then given that you have all this administrative work to do with the AMA, how do you balance being a practicing otolaryngologist and being president-elect and all the other positions you've held?
Yeah, otolaryngology was kind of a late decision for me in the medical school timeline. That back then it was early match, right? So you remember the early match, you had to kind of decide early, like almost mid-third year, if you want to get those rotations in and try to shine for these competitive early match residencies. And in my third year, I started wanting to be a cardiothoracic surgeon. And so all of my rotations that I could fit in were cardiothoracic surgery. And our chairman of surgery at the University of Michigan at the time was a guy named Lazar Greenfield.
Okay.
We called him Laser Greenfield, the Greenfield filter guy.
Oh, wow.
And I ended up doing a surgery rotation. There was a tradition then that Dr. Greenfield wanted to meet with and would offer a meeting to anyone that got honors in surgery. He would have a career sort of planning meeting and discussion. And so I got an honors in surgery, and it was right around that time that I decided, I'm going to pursue a different kind of surgery, otolaryngology. I did that rotation, loved it. And so I'm in my meeting with Laser Greenfield, and he assumed that I was going to do general surgery. I had his book in front of me. He signed it, autographed it, and said, so, what's your plan? Like anticipating, like what programs are you going to apply to? And I said, well, actually, Dr. Greenfield, I decided to become an otolaryngologist. End of interview. Like, the book slides back across the desk to me. Good luck. There's the door, and I was out. But I mean, the otolaryngology department at Michigan was great, and I just liked the entire age spectrum. Everyone goes into ENT at that time because they're enamored by the head and neck aspect of it, just the anatomy, the dissection. So that's why I went into ENT, and it's been great. Absolutely no regrets. Kind of interesting that there's never been an otolaryngologist president of the American Medical Association until this year, and now there's going to be 2 in a row with me. But then, at the AMA, I think the second part of your question was how do I manage my practice in that regard? So it's gotten a little tougher this year. So the president-elect is expected to spend about 100 days a year on the road, and then the president spends about 200 days a year on the road. Luckily, it's something that's not a surprise. I knew it was coming, and because my commitment outside of my clinical practice has slowly been ramping up, I've been doing less and less like super intensive stuff. Right? Like I haven't done a laryngectomy in a long time, even parotids, things like that. In solo private practice, if there's a complication on post-op day 2 and I'm in DC giving testimony, there's a problem. And luckily I'm in a community where even those competitors, the other folks in private practice, they're perfectly willing to cover me. I just don't want to, go beyond what they're willing to do and ask them too much. So I sort of started to do fewer and fewer of those cases. Now it's almost all entirely outpatient. Probably half of my practice is pediatrics, the tubes, tonsils, things like that, deviated septum, sinus stuff. So things that I can manage. I take all my calls, like when I'm out, doing trips for the AMA, my patients have my cell phone number. They text me. They do it properly. They don't abuse that privilege. And so I manage that practice remotely. And if I need, post-op bleed or something like that, I've got people that will cover me. And luckily, maybe once a year I have to call on them for that. So knock on some wood here.
Yeah, there you are.
That's wonderful.
But yeah, so it's working out okay.
Good.
early in the conversation, you had mentioned some of the issues that you saw you could help by going through the organized medicine pathway. As the president, as you move into that role, could you give us more of a little more granular view of what that looks like? What are we advocating for next year? And how do you go about doing that? Like, what does your actual day-to-day look like in the role itself?
Yeah, yep. So I guess let me answer that by telling you kind of what the AMA is focusing on right now. So we have what we've been calling our recovery plan for America's physicians, because when you look at the practice of medicine right now, this is not the heyday. You know what I mean? Like, this is a tough time to be practicing medicine for multiple reasons, and that's kind of what I'll get into here shortly. But it's just a tough time to be taking care of patients. And so when we looked at what is it that's keeping us from being so in love with our work that makes us sort of say, you know what, maybe I'm just going to retire early, you know, burnout, things like that. Yeah. So, and that goes through a lot of people's minds right now. And so, you know, when the AMA looks at that, what we decided is that one of them is payment related. So Medicare payment for our services. Physicians are the only group relative to hospitals and other sort of facility-based payment where our payment doesn't track with an increase in cost, right? Everybody else's does. And so if you look at these graphs that show what hospital payment has done in the past 20 years, it follows, like if your costs go up by 2%, your payment goes up by 2%. It's automatic. It's written into law. But if you look at the physician's payment relative to that, it's down here.
And we get cut every year too.
Exactly.
Yeah.
So when you look at what physician payment has done in 20 years, it's gone up by maybe 6%. It's lagging behind by almost 30% relative to inflation. When I look at what my rent was 24 years ago when I started my practice, what my employees, you know, per hour, you know, payment was back then relative to now, I mean, it's gone up dramatically. And yet for me to not be able to keep up with that and be lagging behind by 20-some% is devastating. And then the other thing that just irritates the heck out of me is that other insurance companies, right? So non-governmental insurance, these nonprofit, but the Uniteds, the Blue Cross Blue Shield, things like that, everybody ties their payment to the Medicare fee schedule. You know, if we're lucky, maybe Medicare plus 20%. If we're unlucky, Medicare minus some percent. But this is tying yourself onto something that you are totally unrelated to. There's no congressional budget that affects what United can pay us or what Blue Cross can pay us. But yet the fact that they sort of say, okay, well, Medicare is going up by 2%, we're going to go up by 2%. That just ain't right. You know, so these are the kind of things that we're focused on as it relates to Medicare payment. Other things that are on our mind, you know, when I see what my office staff has to go through to deal with prior authorization, you know, I see somebody who clearly has some evidence of symptoms of sinusitis, right? Blowing green, yellow snot out their nose, ton of facial pain. And standard is get a CT scan of the sinuses on them, see if there's some obstruction, and then fix it. Every single CT scan requires prior authorization. 100% of them get approved, right? I've been around the block enough in 24 years to know what it is that I need to show to get this approved. 100% get approved, but yet they have to get a prior authorization on every single one of those scans. And you multiply that by how many diagnoses across the million physicians in this country. I saw some statistic that showed that, you know, for every hour that physicians spend taking care of patients, they spend 2 hours, you know, they and their staff working on getting authorization to do the care that they think is best. I saw another one that was, you know, I haven't been able to find it lately, but something like 1.4 FTEs per physician just working on things like prior authorization.
And can I go a step further than that? I know in my office, we run into the problem. They'll tell you to call them and they'll give you a time frame, and then you'll call them, and then you'll sit there at 3:00, and then they won't even be on the phone call for 45 minutes, assuming you're going to get off because you're a busy surgeon. I'm a busy surgeon. You don't have time to sit there for 45 minutes to wait for this. And it just plays this game. It's just another hoop that you're going to, at some point, fail some percentage of the time. And they know that. They just build it into their system.
And that's what they're counting on, right? That eventually some percentage will give up, and therefore we won't have to pay for X. Right? Whether that's this medicine instead of that medicine or a procedure. And, I just had this experience 2 days ago where they wanted prior authorization. They denied prior authorization for a deviated septum. And I had the option of fighting them, spending who knows how long on a phone. I did schedule an appointment that isn't coming up until after the patient had already taken time off to get their deviated septum fixed. But the other option is just to tell the patient, you know, I'm sorry, your insurance won't authorize it. And then meanwhile, that person is going to walk around not being able to breathe and having, you know, headaches from sinusitis. And that ain't right either.
Just delaying the care.
Yeah, exactly. Yep. So Medicare payment, prior authorization. Scope of practice is really also very much on our radar. When we look at the quality of care, the cost of care, the availability of care, and we look at those three lenses and look at scope of practice expansion, none of those things improve by having non-physicians providing that care. The quality, there's plenty of data to show that everything from the care that's delivered anesthesia-wise by nurse anesthetists versus a team that has an anesthesiologist on it, by nurse practitioners versus a team that has a physician on it, that the quality actually goes down. The cost of care goes up. I mean, because there's the surgeons and the anesthesiologists in the room know that when you see an EKG that just doesn't look quite right, or you hear something in the medical history that just doesn't sound quite right, if you don't understand medicine well enough, the reflex is, you know what, better cancel the case, get a cardiology consult, cancel the case, do this, do that, we'll schedule at a different time. An anesthesiologist present there will be like, you know what, this is something that's not going to be that much of a risk, it's not going to add risk, it's not going to do anything that's going to complicate the surgery. This patient is cleared, let's go ahead and do this case. The cancellation rate is much higher when it comes to some anesthesia that is done by a non-anesthesiologist, right? So these are the kind of consequences of scope of practice that have real patient, consequences. It was, we had a bill to expand nurse practitioner scope in Michigan, and the Chamber of Commerce usually is in line with the insurance companies because they don't want to see premiums go up. And they're told that if, the premiums are going to go up if the bill doesn't pass because physicians' care costs more, right? The data shows, though, that cancellations cost money, right? If somebody's waiting to get a procedure done and it's going to take a month, whatever low back pain they have, whatever it is going to lead to more days off of work. And so actually, if you look at the math, it's costing the businesses more to delay the care that somebody needs than paying more for a physician to be involved in that care, right? And all of a sudden, the Chamber of Commerce was like, that's a good point. We're going to stay neutral on this one. And so they didn't sign on with the effort to expand scope. So scope of practice is another big one that we work on.
Can I break in a little
for sure,
on scope? So obviously, the how do we balance that with access, right? That's a big thing that we all deal with, especially for us in anesthesia is, there's counties, rural counties in Indiana where I am, in Michigan here, and in Ohio that don't have even an anesthesiologist who live in that county. So how do we balance the access with that sort of scope of practice?
So I guess my reflex answer is less intellectual, but based on reality, and that is that if you look at any of these, half of the states that have expanded scope of practice for nurse anesthetists, for example, and you map out where the physicians are in that state, and then you take a map of after independent practice where the anesthetists are going in that state, and you overlay them, they go exactly where the physicians are.
Sure.
Right. Nobody is excited to get the ability to practice independently and then go move to the upper peninsula of Michigan from down here to go take care of people. It just doesn't happen.
So then how do we expand access otherwise?
Yep. So we have a huge physician shortage in this country, right? So we're about 100,000 physicians short almost right now, or will be shortly. And so the solution is to improve the size of that workforce, right? And so we need, and the funnel isn't medical school. Right, so we had 3 medical schools in Michigan when I was here, and we've added 3 more. So we've doubled the number of medical schools.
Residency.
But the funnel is residency, right? That graduate medical education funnel. And so we need to expand our graduate medical education funding to train more physicians so that we have enough that where the market demands and pays more, physicians will go, right? But if right now there's barely enough graduates to replace the metropolitan areas, let alone filling those gaps up there. And then there's novel things like, remote, telemedicine is something that can be used, not necessarily for a critical moment in anesthesia, right? Like if somebody goes into VTAC, it's not the time to be trying to get somebody on a Zoom call and say, hey, what do I do?
Right.
But for, somebody that's looking up somebody's nose and says, I see this thing, it looks kind of white. I don't know if it's a polyp or is it a, some sort of CNS, encephalocele or something like that. Can I show you on this? That's perfect for telemedicine, right? So we can be available for care in these remote areas without eliminating physicians from that care because our opinion saves money and saves lives.
I think to your point about the the EKG and the person doesn't look quite right.
Yeah.
And us not canceling a surgery. I think on the flip side, on after surgery, can they go home? Can they not go home? I think there's a lot more the physicians can kind of input, whether it's a regional anesthesia or no, they're actually okay. They're back to baseline.
Yeah.
They don't need to stay overnight, which will then add cost
Absolutely.
to the overnight stay of the hospital
Absolutely.
system. What you touched on before, they all kind of combine for me. Our hospital system had this conversation with us about the cost of healthcare going up, whether it's the mesh, the implants, the devices. Those companies are increasing their costs, but the reimbursements are here. And so finding a way to close that gap, and they're looking at, okay, we just shut down a service line. And that's unfortunate. So I think that's great that you guys are working on closing that gap to not close down service lines. Oncology is a perfect example. There's very few oncologists in certain our areas. If you don't have the coverage, you're sending patients away. And then all of a sudden you impact these smaller communities where we all clearly work.
And they're driving 100, 200, 300 miles in some instances
For
to go
care.
Right.
see a specialist.
Yeah, what's interesting, you mentioned about hospitals and where they are in this, like the scope issue, for example. I was disappointed when we had our most recent nurse anesthetist scope expansion bill to have testimony come from the hospital CEOs in favor of expanding the scope for nurse anesthetists. And the main reason, and I don't think this is me being cynical, is that when the economics of payment for anesthesia services change, and now instead of $100 coming in, anesthesiologist getting 50, nurse anesthetist getting 50, now $100 comes in, the nurse anesthetist gets their 50, the hospital is getting the other 50, right? Because they are the employers and they're managing this. And so this was something that the hospital wasn't getting a dime of in the original situation. They see cha-ching, and they're like, you know what? This is a revenue stream. And they literally were supporting the scope expansion for nurse anesthetists for economic reasons.
Well, and they miss the forest for the trees because that's short-sighted. Because like you said, we talked about, they're missing the cancellations, post-op care, the quality of care potentially.
The efficiency of that care goes way down.
Yeah, interesting. So,
And just, sorry, just to finish up these other priorities I mentioned. So I mentioned Medicare, I mentioned prior authorization, scope of practice, physician burnout.
Yes.
The fact that, again, I mentioned it when we started talking, just the status of physician satisfaction with their job right now is at a low point, right? 60% of physicians experiencing some symptoms of burnout. What was really interesting in a way that was unexpected to me, during COVID, when the world and the country needed us, and we felt we felt like we had a role to play in helping our country get through this crisis, burnout went way down. And then at the tail end of COVID, the pushback when we were trying to vaccinate people and things like that, and what do you guys know? You're trying to push vaccines and things like that. It started to go up again, burnout. And so now we're back up at 60%, which is a tough place to be.
And I think going back to, we brought up COVID, and looking back at it, I was on the front line. I ran our COVID response at my hospital. And it was always interesting because I actually felt like this was on both sides. I felt like we allowed it to get politicized. And so on one side, I had patients telling me it doesn't exist. On the other side, I had patients telling me that everybody was going to die from it.
Yeah.
And the reality was I was sitting there and we're just trying to take care of patients. Like we're really just trying to keep as many people alive as possible. Looking back on the pandemic, is there anything you think the AMA could have done better? Is there, in the response that they did have, how were they responding? Like, was it through the government agencies or what exactly are their ties in? Because I think a lot of doctors and surgeons really don't understand exactly how the AMA plays a role in the bigger structure of medicine.
Yeah. I would say that the AMA's role in something like a pandemic is getting information out there to physicians, our members, but also to the country on behalf of those physicians, right? And very high level. We're not the researchers, we're not the CDC, but we are the people that have the inroads into that communication with the general public and our physician members. And so, looking back on it, what could we have done differently? I think we could have done a better job of explaining the nature of science, right? Everybody expects it to be black or white, right? You put a chemical in there, it turns red or it turns blue, right? Like the Matrix or something like that, right? But there wasn't that certainty when it came to COVID, right? I mean, the fact that I was one of those people that thought I'm going to get vaccinated, I'm not going to get COVID. well, I was wrong. You know what I mean? But explaining the not the labile nature of it, but just the potential that new information comes in and we change our recommendation based on that information, that's the nature of science.
And it doesn't quite mean that the recommendation was wrong.
Right.
We just made that recommendation based off what we knew at the time.
Exactly. And then the example I give a lot, those of us at a certain generation remember peptic ulcer disease was something that somebody got an ulcer, we would cut it out. You know what I mean? My whole residency, my general surgery internship, every day there was somebody coming to the operating room to get a bleeding ulcer cut out and then, you sew it back together. Now we know that that's H. pylori. They don't need their stomach piece cut out. They get antacid medication, they kill the H. pylori and their ulcer goes away. Right? And that was in my lifetime. Cutting out a piece of the stomach, taking some pills and solving the same problem. Right? That's us getting smarter. And so when it comes to COVID, it was the same way. Right? We realize that this is a virus that mutates. There's going to be all these variants, that the potency, the efficacy of a vaccination is going to change. This is mRNA. This is going to be different. You can still get COVID. You're much less likely to die, but you'll still test positive. And then people are like, well, heck, I got my chickenpox vaccine. I never got chickenpox, but now you're telling me I'm going to get my COVID vaccine, but I can still get COVID. What the heck? You know what I mean? And so that was a problem in communication, I think, right?
I do think that, and that's something I think comes on from our side though, as professionals, we come out there and we declare things as almost like they are absolute. And we come out and say, this is right, this is wrong, or this is what you should do, this is what you should do.
Yeah.
And so people being trained to believe that things are black and white
Yeah.
really have a tough time understanding that at the edge of medicine or at the edge of any technologies being developed is a lot of unknown.
Exactly.
And at the beginning of this, there was a lot of unknown, a lot of people acting like they knew things when really nobody knew anything yet.
Exactly.
And that led to just the beginning of a long slide of problems.
Exactly. I mean, and I think to answer your question, it was exactly that in hindsight, we should just share the confidence that we have in a given opinion, right? And if it's 99% confidence, so be it. And if it's at, 50-50, but this is what the data is telling us to do, share that
be honest
ambiguity.
about it, yeah.
You know what I mean? Like, we don't need to have an air of confidence about something that we know, you know what, I'm not really sure. It's the first time around this block. Time will tell, and maybe in 6 months we'll have a different answer for you, but this is the best we can do right now with the information we have. I think we need to be more transparent about what we don't know. And that's kind of one of the lessons from
So
COVID.
I have a question. So we talked about the physician shortage, which leads to some burnout because of staffing shortages. You and I in the past had a conversation about the ACGME.
Yeah.
How do we increase resident numbers? I don't quite know how to do that. I think you would just recommend us we contact them. I'm not sure how easy it is to advocate for that.
Yeah.
But my part two to that would be, what is it that now that we have a forum for us to get the messaging out from the AMA, what do you want to tell the physician force in the US and say, here's why you want to join join your local,
Yeah.
physician administrative work
Yeah.
to join the AMA, or what can you do to increase the memberships?
Yeah.
Like,
Yeah.
what is your advocacy for?
Yeah, I guess when I talk to, for example, medical students or young physicians about why they should join the AMA and what the AMA can do for them, I don't give them a list of things that we can fix, because some will resonate, some won't. You know what I mean? A pediatrician might naively think, you know what, I don't care what happens with Medicare payment. I don't have any Medicare patients anyway.
It's all Medicaid. Right?
Well, the reality is that every fee schedule is based on Medicare, and so we usually have that conversation. But instead of me telling them what we can do for them, I usually have a conversation. I say, what is it that bothers you most about your practice right now, right? Is it payment? Is it malpractice? That sort of thing. And then based on that answer, I can easily, in 10 seconds, most of the time, like 90% of the time, point them to a resource to address that issue that comes from the American Medical Association, or, local, if it's a local issue, or their state medical society. And let them know that this isn't something that they have to navigate on their own, right? That there are resources available. And so basically I ask them for what it is that's bothering them, and then plug them into the resource. And not everybody has the same goals, right? Some people want resources for burnout. Right? Like, you know what? I just don't know how long I can do this. What resources do you have for burnout? We got a ton of that, right? Some people just are sick of this graph of Medicare payment doing this relative to everybody else doing that. And we have a ton of resources, and we have not just resources, but opportunities to engage. And I think the way that you're referencing about talking to lawmakers, right? There's a fixmedicare.org link that you can literally go to. You put in your name, your zip code, and it immediately populates with your lawmakers, based on your district even, that you can contact with one email, and it fires it out, right? And that way they know that this is my constituent now, somebody that they likely know. I mean, our congressman I see every Thursday and Friday walking around the street, and he knows, who this email is from because it's a nice small town like Flint. Sure. But those resources are what you get through the American Medical Association. So you're not fighting this battle on your own, because an individual that is sick of seeing their payment cut like that, I mean, what is their ability to do squat about it? Mm-hmm. Other than contact their local lawmaker.
I heard they could go to law school.
Yeah.
And actually, it's quite interesting now that here we are in Flint, in the Rust Belt. As I told you earlier, I grew up in a city very similar to this from Ohio. And we're looking through downtown, and in some of the areas we talk about reviving and everything that's going on. And I think about a lot of, surgeons and doctors assume that we're going to be talking to the president, president-elect of the AMA, and you're going to be, hey, I'm not.
Ivory tower.
That's not pejorative, like from some ivory tower, and you have no idea. But actually, you have a practice, you have a private practice. You're here living the life that everybody else is living. You understand the real ins and outs. You're not as far removed necessarily as I think some doctors and surgeons may feel that you are. Mm-hmm. But at the same time, the AMA, as I've gone through the process, is always, when I talk to my surgeon colleagues and attendings, especially when I was going through, it was very much, that's not our thing. Like we don't gain anything from it. How do you think that disconnect developed? And do you think that maybe having a surgeon enroll for a few years makes a difference? Or what else can we do to really get out in the surgical community and say, look, we are actually understanding where you're coming from? It sounds like you do.
Yep. So, and the first observation about, sort of being in it versus being in that figurative ivory tower, absolutely, I'm in it. And that helps, right? I mean, it's what's interesting to me, my observation about my involvement at the AMA at this president-elect level, every single topic that comes up that we work on at the American Medical Association, I can look at my own community, my own office, my own community, the public health consequences of some of these things we're working on, and it is directly applicable, right? And so I think it does make me a better spokesman for physicians, and not being insulated with multiple departments and, like things like prior authorization, for example. When we have a prior auth issue and somebody's not getting prior auth, I get a message within 60 seconds of that phone call about, we're having trouble getting this off. If I was in the ivory tower, I probably wouldn't it wouldn't even ever be on my radar. Yeah. You know what I mean? And I think that's helpful. But your question about what role the AMA has, or the history of maybe why people might think they're disconnected, that the AMA can't help me. I think it depends on what headlines reach them. You know what I mean? And so, for example, one of the most polarizing things that I've seen in my career at the AMA was when the Affordable Care Act came up for conversation, right? Do we or do we not support this? And the AMA came out in support of the principles of the Affordable Care Act. And immediately, 40 to 50% of physicians were like, no way, over my dead body, I'm going to drop my AMA membership. That's not at all something that we should be doing. And now it's gained popularity. I think it's at a point, I don't know what President-elect Trump is going to do, but it sounds like he wants to dismantle portions of the Affordable Care Act. I think public opinion says otherwise, right? Now that it's been around for a while, it's something that has grown roots, and I think people don't want to see it go away. Tweak it, sure. Lots of things that can be improved for sure. But that's the kind of thing I think that turns people off and says, you know what, they're not doing anything for me. And they remember the one thing that made them feel like there was a disconnect. But what they don't realize is there's 5 things, Medicare, scope of practice, prior authorization, physician burnout, the role of telemedicine, things like that they completely agree with. And I think that once we can explain where the similarities are, the affinity, the things that draw us together, where we are perfectly in line, and ask them to say, you know what, we're not going to agree on 100% of things. We just came back from our interim meeting, and there are some things that passed by a 45%, right? Where 45% of the people in the room didn't agree with it, but the majority did. That's the way things work in this country. And so once we can sort of get past those polarizing topics to the core issues that really unite pretty much every single one of us, like the 5 things I mentioned, that's when I think we can start to get through and show them the value of AMA membership.
I think we can start moving that needle, even now, just getting your messaging out today to our listeners. I think that's moving the needle in the right direction already.
Yeah, no, I definitely appreciate that opportunity because again, how does that get communicated if they don't happen to tune into this?
Sure.
Right? There's a boatload of mail that we send out.
Sure.
You know what I mean? And you know what happens with that kind of mail. It ends up
Yeah.
in the trash.
So the other question I would have is the flip side of what can the AMA do for us? What can we do as, I think we're all members of the AMA. I mean, I send my money in and I kind of follow along, but I don't do anything active. What can we do as members of the AMA to support the AMA, who can in return support us?
Yeah, I think that you're already doing the basic, right? You're a member, you're supporting the efforts of the American Medical Association to do all those things that I mentioned. Nothing more needs to be done, right? Because we're all busy, right? We should pay for the advocacy that somebody is giving us, but time versus dollars are two different things, right? And we're getting your dollars and dues, and we're doing the work with it to pay for the people that are talking to Congress and about issues, or talking to state legislatures, or dealing with public health issues. If you have time, if you have an interest, there's also that opportunity. Like, for example, you could easily say, you know what, I'm going to go to my partners, and we're all going to go to fixmedicare.org, and we're all going to log on, and we're going to send these emails, and we're going to let people know. I'm going to find out who my local lawmaker is. I'm going to make sure I'm going to set up a meeting with them. We're going to go out for dinner, and I'm going to let them know why they need to vote this way on a permanent Medicare fix. The thing with Medicare, a little tangential comment, every year we beg not to be cut. Every year that I've been in practice. There's actually a bill now, HR 2474, that fixes it permanently, that does exactly what everybody else gets, where the Medicare Economic Index drives what's going to change with Medicare payment, not a budget process. But if you support that, that's absolutely something beyond just sending in payment for membership. Engage with lawmakers on things that are important to you. And if it's not Medicare payment, if it's something about physician burnout and mental health of physicians, if it's something about scope of practice, there are many opportunities to get engaged. And if you really want to get engaged, through your specialty society, through your state society, coming as an alternate delegate or a delegate to our House of Delegates and voting and being one of these, hundreds of people that are voting on a 55-45 vote or a 100% vote, that's the other level of engagement. And so there's many opportunities from, sending in a credit card number to become a member, to coming to 4 meetings a year and making the policy, and then everything in between.
I think for us in anesthesia, we get cut every year.
Oh, yeah.
Oh, yeah.
So that's big for us.
Absolutely.
But I think that's the question is, we've known that this happens every year for decades. I mean, since I was probably in medical school, I've heard about it. I'm sure it's been going on before that.
Yep.
What is the reason why this hasn't been fixed permanently till now? And what are the chances that this time it's going to actually go through this Congress?
Yeah. So as far as what is the reason it hasn't been fixed, I think that in the time that I've been involved, we beg not to be cut. And sometimes we actually eke out a 1 or 2% increase. And then that's victory. You know what I mean? And we're like, phew, we didn't get cut. And that's what we've been doing, right? And that's been the measurement of success, whether or not we get cut or not. And then the next year we do the same thing again. This is a permanent fix, right? And we thought we had that with the SGR before, and getting rid of the sustainable growth rate and that sort of thing. But it's the same problem with a different name now, where it's still an annual budgetary process. And so what are the odds? Man, I wish I could tell you. I'm kind of an eternal optimist. I had T-shirts made for our entire board that say HR 2474 on it, because this is what I'm looking forward to passing. It just so happens that it'll probably be under consideration in the year that I happen to be AMA president. How awesome would that be? Being AMA president when a permanent fix for Medicare. Whether that'll be this year or the year after, I don't know.
I think my next question would be, as Surgeon and part of our platform, when that comes up or as we approach that time, can we reach out to you and see how we can help you make that happen? I think
100%.
that everybody involved in this would definitely love to see an answer or a solution to this problem. You'd be the AMA president of life.
Yeah.
If you can help us fix this.
Well, we definitely congratulate you on the election. We wish you all the success, that this is the year that all that happens. And we want to continue the conversation
For sure.
In the future, but we want to be respectful of your time. We appreciate you coming here tonight. Did you have any closing questions, remarks?
I was gonna ask the question about the GLP-1s. I mean, it's such a
Oh,
hot topic, so
let's do it.
I would,
Let's do it.
I would
Let's
love
do
to
it.
dive into the GLP-1 question.
Yeah,
So, I mean, obviously, GLP-1 agonists are a big part of the medical community now for weight loss, for prevention of cardiac issues, that sort of stuff. It's big in us in anesthesia because of these side effects that we deal with in the operating room. So, I'd just like to get your overall take on the GLP-1s. What do you think the current state is, the future?
Yeah, no, I mean, it's an exciting development with a whole lot of unanticipated consequences, right? Like the anesthesia component of these GLP-1s and screening for that and the pre-op, the PAT was something that wasn't even on my radar
Yeah.
more
A year
than 3
ago.
months
Yeah,
ago.
right,
Yeah. And
Until
now
we
it
started
is.
canceling your case.
Right, exactly. Yep. And so there's that aspect of it is the public getting excited about something before the science is ready to support that excitement.
Yeah.
And then also the economics of it. I mean, this is something that is expensive. And when it comes to prior authorization for things like this, I don't have a problem with prior authorization. This isn't in that category, but the analogy is similar. When I turn on the TV, I go home for lunch. This is the luxury of being in a place like this. My office is 7 minutes from home. My last patient's at 11:45. At 12:05, I'm home. I have lunch. I take a nap. I go back for afternoon. During lunch, I turn on the TV. Every single commercial segment has a pharmaceutical advertisement.
Yeah, that's
true.
I've gotten into the habit of going to GoodRx and checking the price of everything I see. Nothing that's advertised is less than $1,000 a month, sometimes tens of $1,000s a month. And so I don't have a problem with prior authorization for something that cost $100,000, right? But it is something that the indication, the science needs to support the indication. Just because it can help with weight loss, we need to wait for the science to determine, okay, is this the right way to do it? And if so, and the science supports it, then absolutely we're going to advocate for better pricing of it, better availability of it, and make sure that patients can get what they need. And if it happens to be expensive and happens to need to go through prior auth, I don't have a problem with prior authorization for something that costs that much money. What I do have a problem with is prior authorization for every CT scan that costs $200 that gets approved 100% of the time. That's a waste of my time. Prior authorization for an expensive drug, not so much a waste of time.
Yeah. All right.
So,
Well, we're gonna pick up where we left off. I think we'll see you in 6 months.
Looking
Hopefully
forward to
we'll come
it.
back to visit you in Flint.
Yep, unless everything is fixed by then and perfect, but I have a feeling we'll see you again
If
in
that's the
6
case, we'll
months.
go out and celebrate.
Yeah.
Absolutely. Party time.
All right. Well, thanks everyone for joining in tonight. This is Dr. Bobby Mukkamala here in Flint, Michigan, our president-elect for the AMA.